Imagine if we tested prostate cancer drugs only on female cell samples, or created anti-smoking campaigns only for men. Does that make sense? Men, women, girls, and boys are similar in many ways, but when it comes to our health and well-being, our differences matter. Every cell is sexed, and every person is gendered. Sex and gender influence our risk of developing certain diseases, how well we respond to medical treatments, and how often we seek health care. Did you know that in Canada, men typically die younger than women, yet more women than men struggle with chronic illnesses? Why? These are complicated questions. The more we understand how sex and gender affect health, the more we can improve health and well-being for everyone. It starts with better science. As part of the Canadian Institutes of Health Research, the Institute of Gender and Health fosters research that explores how sex and gender influence health. We use these findings to tackle the biggest health challenges. Our vision includes everybody: men, women, girls, boys, and gender-diverse people.
My name is Cara. I'm the Scientific Director of the Institute of Gender and Health, and I'm thrilled to be here to talk to you today about how at the Institute of Gender and Health we try to accelerate research that integrates sex and gender into the delivery of personalized medicine at the point of care for men, women, and gender-diverse people. When Jane and Peter walk into the doctor's office, the question is whether they should be treated differently. Science says yes. Genetically, men and women are different. Women have an X chromosome with 1,669 genes. Men have a smaller Y chromosome with only 426 genes. We know that physiology is different. We know that biology is different between men and women. One of the most exciting breakthroughs that we've had in science is learning that chronic pain is actually mediated by different immune cells. In animal research, we've learned that in the spinal cord, it's the T cells that mediate chronic pain, whereas in male mice, it's the microglial cells in the central nervous system that do most of the work. This shouldn't be surprising because we know that men and women even process drugs differently, and that probably in the future, we may not even be giving the same medicines to men and women. We know that women have more body fat, which means that fat-soluble drugs may linger longer in the body. In the liver, female hormones can affect how drugs are metabolized, and there may be over or under expression of certain cytochromes and enzymes that activate or inactivate drugs. Women's kidneys, on average, are smaller than men's, which means that renal excretion affects how the drug is eliminated from the body. And then pharmacodynamically, in the heart, for instance, we know that women have longer QT intervals, which has an effect on whether drugs are able to provoke arrhythmias in men or women differently. And of course, women tend to be smaller than men, so the same drug dose might have a bigger effect. Even when you control for weight, we see that the bioavailability of drugs can be different in men and women. This is why people perhaps were not surprised when the United States government did an audit and found that of the 8 out of 10 drugs that were withdrawn from the market in a given decade, 8 of those drugs pose more of a threat for women. Medications like the allergy medication Seldane or the heart reflux medication Cisapride caused fatal arrhythmias, torsade de pointe, in women more commonly than in men. You may not know that there's already sex-specific drug therapy on the market. Nocturna, which is a medicine that's been developed by Ferring for nocturia and retention of water at night for people who go frequently to the bathroom, has now been shown to be more effective if men have a higher dose of this drug than women, because at the higher dose, women are more susceptible to hyponatremia, seizures, and serious CNS effects. So it's already happening not only with this drug, but other drugs. For instance, there's Health Canada warnings against the sedative hypnotics that recommend that women should have a lower dose of Zolpidem, a sleeping pill, than men, because the next morning women's blood levels are 45% higher than men. But what I really wanted to talk to you about is whether there's value in some of the lessons that we've learned at the Institute of Gender and Health for transforming science and practice around gender medicine, and if you think they could be applied in your center, in your practice, and in the daily work that you do. Now, our strategy has been to integrate sex and gender across our funding opportunities. In green, you could see that ethics boards ask if women, pregnant women, and if sex and gender are adequately being included in research protocols. We've been pushing basic scientists to include female and male animals to look and see if there's differences and if we might be missing something. In human research and clinical trials, not only do we want women to be included, but we want the results to be disaggregated by sex so that we know whether response to drugs, toxicity, or efficacy differ. You'll see that we've been working with journal editors to make sure that the science that's published truly includes sex and gender and any differences. And finally, we've been working with practice, policymakers, and the general public to make sure that the results of research get transformed at the point of care into health impacts that truly improve the health of all patients. We have 5 winning strategies that I wanted to talk to you about. The first is to measure and monitor what you're doing. The second is to build capacity. The third is to incentivize, and the fourth to coach so that we really do better tomorrow than we're doing today. And finally, I'll end with telling you a little bit about what's happened when we've audited the health research outputs and whether they're getting into clinical practice guidelines at the point of care. Our first strategy is to measure and monitor. At the Canadian Institutes of Health Research, we ask all grant applicants to indicate in a box whether they're taking sex, biological factors, or gender, sociocultural factors into consideration when they submit their research protocol. In 2010, the first time we asked researchers this question, only 20% said that they had really thought about this. But by asking and monitoring each year, we now know that over 60% of researchers are changing the way they practice science in order to see if there are sex differences and if they could contribute knowledge in this area. The second thing that we've done is to build capacity. I invite you to go to www.discoversexandgender.ca and check out the 3 online training modules that we've developed. One is on biomedical research. The second is about primary data collection with human participants. And the third is about how to analyze the data that's been collected or that you have in your clinical or administrative databases to see if we should be delivering care differently. This is what the questions look like. It's an interactive module. We might ask something like, which of the following is a sex-related variable? And as you can see from the answers, all of them are biologically based and have differences between men and women, so the answer would be E. All of the above are sex-related variables. Once you finish the module, it's possible to download a certificate of completion. And what we've done to incentivize both clinicians and researchers when they do clinical research is to make it mandatory for them to submit this certificate in order to show that they have sufficient knowledge of sex and gender to receive funding for instance, as you could see in the slide, personalized health grants. So if you wanted to deliver a new approach to personalized health, you'd have to show that you're really taking into consideration sex and gender when you treat your patients. Over 2,000 individuals have completed our sex and gender modules. I encourage you to check them out. We're also working with journal editors to see if editors would be willing to refuse to publish research if sex and gender aren't taken into consideration. JAMA, The Lancet, Nature are all paying attention to this important area, and I think that you're going to see some surprising changes if you try to submit a paper and it's not analyzed properly so that the results benefit everybody. Our fourth strategy is to make sure that we hold people's hands as they embark on what may be a scary and culture-changing approach to practicing medicine. And we do this through use of our sex and gender champions, which are actually expert team members who could help bring the knowledge to improve care. Here's an example of how we use our sex and gender champions. We recently had funding for a team grant called The Impact of Gender on Knowledge Translation Interventions. Is it important what words you use? Is it important how you consider dissemination networks? Having a sex and gender champion on the team to advocate and speak up for these important considerations can change the way research is practiced. And finally, I wanted to talk to you about our work on the clinical practice guidelines. I imagine where you are, you also use clinical practice guidelines to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. We recently did a survey of all the clinical practice guidelines that were published in Canada between 2013 and 2015. 2 and 3 accounted for sex and gender, which is great. But only 30% of these, or 20% overall, made sex-specific diagnosis and treatment recommendations. An example of what a sex-specific drug recommendation might look like is in diabetic patients, aspirin is effective for reducing the risk of non-fatal myocardial infarction in men, but not women without a history of cardiovascular disease. That's great. But many things weren't mentioned. We did not see mention of other sex-drug interactions, even though females have nearly double the risk to develop an adverse drug reaction compared to men. In future clinical practice guidelines, we would like to see the evidence on the statins, how they cause more myalgia in women, how there's more bleeding risk with some of the new oral anticoagulants in women. We'd like to see those integrated in clinical practice guidelines. So what did we do? We went to speak to our professional societies. Perhaps physicians, some of you in the room, may be members of a professional society. We approached the Canadian Cardiovascular Society and said, for your clinical practice guidelines, would you be willing to have a gender champion on the team so that you can make recommendations specific to men and women? They welcomed us with open arms, and they said, yes, let's put a sex and gender champion, for instance, on the new clinical practice guideline coming out about the management of ST elevation MI. And by having this champion and expert, we'll be able to make the proper sex-specific recommendations that will lead to a change in practice. I'll leave you with these ideas. If you want to accelerate personalized health for men and women at the point of care, then be the gender champion on your clinical practice guidelines. Speak to your professional societies. If you have a drug representative come talk to you about a new drug, ask if they could show you the data about efficacy and toxicity and differences between males and females. Next time you go to a conference, raise your hand and ask, thanks for showing me the results, but were they different for men and women? And can you tell me how? In practice, talk about the sedative hypnotics and other drugs that now have recommended dosing differently for men and women. Teach residents about the different biology. And if you actually give lectures in medical school, then please talk about the physiologic differences so that the next generation of clinicians will understand that personalized medicine, in many cases, means treating men and women differently when they sit in front of you as patients. Thank you.